Good afternoon, everyone. We will go ahead and get started. Welcome to the Stroke Quality Exchange Call. My name is Diana, and I will be your moderator today. Feel free to ask questions throughout the presentation by typing them into the chat box on the right hand of your screen, or pressing the microphone at the bottom of your screen, or if you're using audio, press *6 to come off mute. The slides and links to the presentation will be sent out within 1 to 2 weeks from today's presentation. I will now turn over the presentation to Deb Moss, our Senior Director of Quality.
Thank you, Deanna. Thanks everybody for joining us on our Stroke Exchange, Quality Exchange call. This is actually our first one in 2020. Typically we do this quarterly. We have a really full agenda, and I really hope that you all enjoy this presentation. Feel free to come off mute, ask questions, or type them in the chat box. Deanna, you'll have to tell me if there's any questions because I cannot see the chat box at this time. But just to quickly go over the agenda, we're welcoming you now. I'll talk a little bit about day-to-days and the reports that you should have received. If you did not receive a report, please reach out to your director and we can make sure that you get those. We're going to talk a little bit about the PMT updates. And then we have a special guest for best practice sharing, Shantah, I hope I said her name right. She's from Baylor Scott and White in Plano, and I'll tell you a little bit more about her and what she will be sharing with us. And then we have some preliminary data on COVID-19 and the effects on stroke. When we send out our presentation, those slides will not be included because this is very preliminary data, but we found it very interesting and just wanted to share the information that we're seeing so far. We will then talk about some educational opportunities for you, and then talk about how you can promote your Get With the Guidelines Stroke Award. So it's a full agenda. Hopefully we can get through all of this in a timely manner. Oops. So first of all, just to talk about Get With the Guidelines Stroke Registry, how can it help you? Well, it helps to promote consistent adherence to your latest the latest scientific treatment guidelines, produced typically are published by the American Heart, American Stroke Association. There's some real-time reports on guidelines, supported metrics that allow your hospitals to continuously monitor performance and check on your correct course. And you can also benchmark against lots of other hospitals in order to see how you're standing up from those metrics. There's the ability to drill down to identify your outliers. You can focus on improving systems of care. And there's numerous studies that demonstrate that Get With the Guidelines success in improving patient outcomes. So day-to-days in the Southwest region. First of all, there's some measure changes that you need to be aware of for this next recognition period. So one of the things that happen is our achievement awards have now, we've added 2. So one of them is arrive by 3.5, treat by 4.5 hours for IBTPA, and that replaces the arrive by 2, treat by 3 that the Joint Commission is following in their performance measures. The other new one that's been added is the intensive statin prescribed at discharge. So those 2 are now part of your Get With the Guideline recognition for achievement measures that need to have 85% or higher. You know, we have the gold, silver, and bronze levels, and so the bronze level is 90 consecutive days. The silver is 12 consecutive months, and the gold is 24 consecutive months at your 85% or higher on that achievement. And then if you are able to attain that, which a lot of people are, and I'll talk a little bit about that, then there's also the quality measure awards, or the plus measures, and those you have to have 75% or higher on at least 5 of these measures. And now there are actually only 6, and that is just for the silver or the gold to be eligible. So at the bronze level, you can't achieve the plus measures. Then we also have the target stroke. which is honor roll 75% or higher of door to needle 60 minutes or less. The honor roll elite is 85% of applicable patients with a door to needle less than or equal to 60 minutes. And then the elite plus would be 75% of the applicable patients with a door to needle of 45 minutes and 50% of the applicable patients door to needle of 30 minutes. So those are those three different levels. And then we also have the honor roll advanced therapy level that is a new one this year. And that's 50% of applicable patients door to device less than or equal to 90 minutes for direct arriving patients, and for the transfer patients, 60 minutes or less. So those are the main achievement levels. And I know that you've not received your awards yet, but they will be coming. Hopefully you'll start receiving those by the end of the week or the beginning of next week. We do have them ready. We're just waiting for our marketing kit so that we can get those to you. But just to give you a really quick overview, I'm going to tell you just the number of awards and just split these out. So some people have received several of these awards, and some have not. But we have 13 hospitals that will receive the participating award, which means that you just started the program and you have at least 30 patients in, so that you have a benchmark. The bronze award at 3 months is, we have 9 hospitals that have achieved that. We have 3 hospitals that have achieved silver, 21 silver plus, 3 gold, and 154 gold plus. So altogether, there's 203 hospitals that have received at least that first level of awards. And then just to quickly look over our target stroke honor roll, there's 23 hospitals that have achieved that for this last year for your awards. There are 88 elite hospitals, honor roll elite, and 16 hospitals that have earned the elite plus, which is really an amazing feat. That's not an easy thing to hit. And we also have 4 hospitals that are going to be recognized at the advanced therapy level. And in addition to that, they've added the new target stroke 2 diabetes honor roll, and 97 of the hospitals have achieved that. So congratulations to all of you guys. It's just showing the hard work that you've put into all of this. And again, you will be receiving your awards very soon. So hospital year-to-date report. You should have all received a report that looks like this. It's got all of your performance measures, your performance achievement measures. Number 1 there in red is your new one. And then number 7 is your new intensive statin. So you should have gotten a report like this that's color-coded to say, if it's red, then you can drill down, take a look at those patients and see if maybe there's something that you missed in the documentation that you can add, that you can overturn that patient, or maybe you just missed some documentation. So you're able to drill down and look at those patients specifically. And then also the target 2 diabetes honor roll. It's actually a composite measure of all of the measures, and it needs to be 90% or higher. And there's a link to the composite of all measures on your particular report and in this presentation that you'll receive. So how do you run a grid report on stroke? So you want to get in there, you want to see what exact patients do I need to look for that may have fallen out. So you type in your name like you typically do in your participant login, and then click on the reports icon that's next to stroke, as pointed out here. Click on configurable measures. Select the time period of interest, and annually January 2019 to 2019 is typically going to be if you're looking for your awards patients. Then running to drill down to the fallouts. So when you run your report, you hit your patient records. So say, for example, you want to see, I've had some patients that fell out on the measure for IV, TPA, arrive by 2, treat by 3. So you want to look into that. So you select that measure under your additional measures population report, then hit format and go down to choose and select generate reports. This is a report that you're going to see. Actually, you'll see the once, but then you can turn around and export that report into, and then at the top there where it says numerator, you can add your filters. There's filters up there, so you can add a filter. You can put these in order, or whatever you want, and then you would just want to look at those that say no in your numerator. So below, whoops, sorry about that. So down below here, it shows you how to hit your sorts, and then you want those that are included in the numerator only. Once you hit that, then you can actually click right on that patient ID number, and it will take you right into your patient record. So you can review that record, make any changes that need to be made, and change that again. Does anybody have any questions about that?
Hi, Deb, it's Tiana. They didn't have a question. The question I have right now is 300 out of how many hospitals? I'm assuming was the award question.
The 203 hospitals, I think for their Southwest affiliate, I believe we have 287 altogether. Nationwide, I don't know. All I'm talking about right now is our Southwest affiliate, and that includes Texas, Oklahoma, Wyoming, New Mexico, Arkansas, and I'm missing one. Who am I missing? I don't know, I'm missing one. But anyway, it's our
Arkansas,
6 states.
Colorado, New Mexico. I'm sorry, Deb.
No, say it, please.
Arkansas, Colorado, New Mexico, Oklahoma, Texas, and Wyoming.
Thank you, Cassie. Oh, just wondering how many hospitals receives awards as a percentage of the total. I'm not sure how to answer that question, because there's so many different levels of stroke awardees. You know, you have your regular gold, silver, and then you have your plus measures, and then you also have your target stroke measures and your target diabetes measures. So there are so many different levels. I mean, we could look at just the bronze, silver, gold, those, and see the total number, but I would have to do a little bit more looking into that. Any other questions? Oops, you changed it since last year, so I just went to, oops, I missed that. What was that question, Deanna? Can you see it?
Oh, sorry, yes. They said they changed significantly since last year, so I just want to be able to communicate how it has changed, bronze, silver, gold, and would be helpful. That would be helpful.
So the measures within the awards, is that what you're asking? Because we have that measure sheet. This measure sheet, is that what you're looking for?
Hey, Deb, it's Allison. I'm wondering if she wants to, she's going to follow up via email, but probably just to see how the impact of the award measures has changed and how it's affected the numbers of hospitals that are achieving award recognition overall.
Oh, okay. All right. Send me an email and I will look into that.
Hey, I have a question. This is Mari Carmen. We are having some trouble getting our intensive statin therapy up to where you guys want that. The Joint Commission and the American Heart Association don't really suggest that in the guidelines, and I can't get my neurologist to back it up. You know, I have a lot of patients out here that are that do have high cholesterol, but they have symptoms related to their statin therapy already, and my neurologists are not going to increase that dose just to make get with the guidelines happy. But without that, now that we have to make all 8 of those measures, that's not going to happen. So how are our other facilities getting that to work?
Well, I think, you know, if there's some documentation that your physician said LDL's at goal, or patient, if there's anything documented anywhere that the patient would not include or would not support or would not the higher intensity dose, then you can mark that as an exclusion, and then it'll throw those measures out. So if there's any documentation, sorry?
Can I just be really candid here and wonder why, as a stroke program, we are held to standards that are not suggested in the stroke guidelines?
So it actually is. There's actually a, this is part of the new science that was published a while back about the statin medications. And so Get With The Guidelines is following those recommendations.
Those are the diabetic recommendations, right? Those are the diabetes recommendations.
No, I don't think so. I mean, I can send you the link for the science behind that. And there is a link within your Get With The Guidelines. If you go to your coding instructions, there's a link there that you can find that will take you to that article.
Okay.
Okay. All right. So PMT updates. So our the COVID-19, you know, that's affected all of us very over these last few months, changed a lot of things. So there's been several questions that have been added to several of the Get With The Guidelines programs. So this is just a basic overview of what was added to which program. So the modules, the stroke, and stroke, these three. The element description is here, the logic about that, and then when it was released. So this will be available for you, but it's your work today that's driving the future of healthcare. So it's really interesting to see some of the things that we are already seeing from the effects of COVID-19, which we'll share with you in a bit. Then we had an update released April 22nd. The enhancements for that was they added the e-cigarette use vaping to the medical record, the measure bundled updates so that it included all of the new measures so that you would have your bundled so you can run the one report. New reporting measure, reasons for no alteplase, mild and rapidly improving stroke symptoms. Hopefully you all know about that and how it's no longer acceptable to have just rapidly improving stroke as a exclusion for TPA, and mild stroke behind in parentheses it says non-disabling. So those are a couple new things, and the reason behind that is because there's so many patients that have not been treated that had a low NIH stroke scale, particularly the posterior circulation strokes, who are not being treated when they do have disabilities. So there's a lot of research that's been done around that, and there's actually a webinar that's really good that we'll share with you a little bit later, how to take a look at that. And then the EMS layer updates, the severity scores, we've added the VAN and the MPSS as choices, and then various measure descriptions and logic updates. Additional updates, there's a new billing email address that's added to your home page. So if you can make sure that your bills will be sent, your invoices for Get With The Guidelines will be sent to the appropriate person if you put that information on your home page. And then AHA, TJC, the comprehensive and PSC benchmark groups within the PMT have been updated as of April 22nd. Then again on June 3rd, there was an update, just a few enhancements there. That was the history of the emergent infectious disease added to the medical record. That's the COVID-19 stuff. And then the ICD-10 was added for COVID-19 so that can be recorded as well in your ICD-10 other diagnosis codes. And then there was updated filters. So the new emerging infectious disease filter is now available, and this is what that looks like. So you can run your report, and then you'll see what your reports look like there. And then also the medical history filter. the history of infectious disease. So those were the June 3rd, 2020 updates. And then most recently, we've had an update on the 27th of June, and that has enhancements, the acute ischemic stroke guideline updates. So there's some updates to your forms, the forms that are available that you can print for the actual tool. There's some label changes. We've added to thrombolytic because they now have a choice that connect the place now is all available. Logic was added to medical history. Specifics manual updates for the coding instructions and the measure updates for CSTK, STK. And now if you go to your coding instructions, there's actually a link that will take you right to the Joint Commission definitions for what they're looking for their CSTK and STK measures, including, what's included in the fields, what's excluded, and all of that kind of information. Additional updates is there's a frequently asked question document. There's filters added and updated. The EMS agency list search has been enhanced, and then the form control update for delay in IV thrombolytics. So any questions about that? Anything in chat box?
Nothing yet.
Okay. All right, so moving on to best practice sharing. So as I mentioned earlier, we have Shantah Sinki, I hope I'm saying that right, but Shantah has agreed to share with us some information that they have worked on, some process improvements. So just to give you a little background, she's the quality program, the program outcomes manager and the stroke coordinator for Baylor Scott and White Medical Center in Plano. She's been a registered nurse for 15 years with most of her experience in intensive care. She started her stroke career working with her mom, doing stroke program development nationally in 2015. And this experience led her to become the stroke coordinator in 2018. Within 10 months of being in her role as stroke coordinator, she led her Baylor Plano team to become a comprehensive stroke center. Her passion for stroke motivates her to strive to build a successful stroke center where excellence is a constant and an expectation for all. Chandra is going to share with us how she was able to obtain 30 minutes or less door to needle 30 minutes or less 100% of the time in 2020. So thank you for sharing, and I will turn it over to you.
Hi, Deanna. Just before we turn it over, I did unmute Shantah.
Okay.
But there is a question
Okay.
on the chat box. Are there any plans to add DMV Measures links in addition to the TJC manual updates?
So that is something that we are actively working on right now. We recently had a meeting with some DMV representatives, and we're actually looking at, first of all, what measures are different. And then we're also going to look at how we can get that extra layer added. So it is something that we're actively working on. I do not have an estimated date that'll be completed. I'm sure it's going to be a while because we're still looking right now at crosswalking and making sure that the information that we need available for your DMV sites are there in the PMT. I hope that helps answer the question. Okay, any more questions? All right, I'm going to turn it over to Shantah. You may need to *6 to unmute, Shantah.
Can y'all hear me?
Yes.
Okay, perfect. Yes, Deb, thank you so much for inviting me to share our practices and kind of what's led us to becoming so compliant with our door-to-needle times. So just to kind of debrief, this slide presentation is something that I created for I did a Quality Summit project, and so this is part of my project that I did. So I'll kind of go through these quickly. I know we're kind of stretched for time. So if you want to, kind of what we called it is our ED department developing code stroke fever, and we're going pandemic. Next slide. Next slide. So as we were beginning to, the previous slide, sorry. As we were beginning to, yes, the next one. As we were beginning to determine why, looking at our door-to-needle times, as everybody knows that we're all working on trying to decrease those times as much as possible and to give our patients better outcomes. So we needed to look about why are our door-to-needle times so long. When I first, and this started in June and July of 2018. So looking at this process, we determined, you know, basically that we were delaying or activating our code strokes. Patients were coming into our triage room. They were going straight to an ED room and then being evaluated by a physician and a nurse at that time. So we were going from triage to the ED room. The nurses were starting their IV, getting everything done. Then we were going to CT scan. So that was part of our delays. We recognized that the physicians were looking at the dictated result of the CT and not the actual time that the radiologist called. There seemed to be a lack of knowledge of understanding the clinical practice guidelines that, you know, about the time metrics, understanding why the metrics are so important. It's not about just meeting a number. And then looking at our delay in our CTA times. The next slide. So real quickly, we looked at those and when I first came on, and then in August of 2018, we changed our process. So now the patient started going straight from the triage room where they were evaluated by the ED physician and the ED charge nurse, and they would evaluate whether, yes, this is a code stroke or not. They were immediately taken to the CT room. In the CT room is where the nurse would start the IV. We would begin the imaging, and then we would do a CTA if possible and if needed. Then they would go back to the ED room at that time. So it changed the mentality of getting the physicians more comfortable with administering alteplase and more about understanding the clinical practice guidelines. Next slide. So as you can see, when we first started, when I came on in May of 2018, so looking at June and July of 18, our door-to-needle times, our mean time was 79, and we were meeting 0% compliance for 60, 45, and 30. And of course, any stroke coordinator coming on sees that, and they're like, oh my, we have some work to do for sure. So of course, that's when we implemented this initial change, which was in August of 18. And so we still, throughout August and September and October, we're still not meeting our goal. We were still 75-minute door-to-needle time mean, and then still 0% compliant. The next slide. So we began created our code stroke team that worked on our process. We were doing 100% concurrent reviews on every single code stroke patient, not even the ones that just coded out stroke. Every single one that walked through our door, we would begin and audit the process from beginning to end. We revised our code stroke process, which we already went over and showed kind of what we did, our first changes that we did. Next slide. So then cycle 2 came, and this was November to December 2018. We continued to educate the physicians regarding our door-to-needle times and decision time for alteplase. We gave them all the physicians individual feedback and gave them more real-time feedback. And we recognized the ED providers for their best practices and for when we had great alteplase administration. So at the end of December 18, we are done better. Our mean time was down to 36 minutes. We were meeting our goal for door-to-needle time less than 60 and 45, but we weren't hitting our goal less than 30. So we continued our process. Next slide. Part of this supporting content, one thing that we did was giving feedback to the staff and letting them know how well they did and what was missed in a real time. We did that, tried to do that within 24 hours for the staff. That helps greatly by letting them know, be aware of what the process was and what they missed so they could work on it. We developed stroke champions. So we have stroke champions in all the units, from the ED to the IR to the ICU and all of our units. We'll even have them in our imaging department, and they wear these little brain on their badges that designates them a stroke unit champion. Next slide. So then the next cycle was January of 19 to April. And during this cycle, we recognized that we were still not meeting our 100% goal of less than 30. We were doing overall well with our less than 60 and less than 45. But we continued to educate the physician and nurses. We incorporated VAN assessment into our triage screening in the ED to help eliminate, kind of determine which patients needed the CTA. We originally were CTA in every single stroke patient that came in, but then we incorporated VAN assessments because not every patient needs a CTA right away. So we were only doing those for the suspected large vessel occlusion. We continued to provide individual feedback, monitoring all of our code stroke process data, and recognizing those physicians. And then we incorporated our any reminders, any kind of changes. So our code stroke team involved every aspect from ED, imaging, physicians, to neurology, to our IR department. Everybody was involved in our team. Next slide. Next slide. So cycle 4 was May of 19 through December of 19. We continued the process of what we were educating the providers. We did notice that our dural needle times dropped some. We were only 80% compliant for 60 and 45 and only 20 less than 30. So during that time, we realized we have a lot of new staff on board. And so new staff in the ED, we were a little bit short-staffed, so we had to use some reward staffers. And so we developed a checklist. Next slide. To help for those staff that don't do this all the time and then aren't as familiar, or they're some of our newer nurses, we developed this all-to-place checklist that kind of goes through, and it gives them all the checklists and the requirements of everything that they need to do for their all-to-place infusion. And also, anytime we didn't meet our goal, so if we had a code stroke came through, we did all-to-place. If we did not meet all of our times for door to first vital sign, door to first neurocheck, door to less than CT complete less than 20. If we didn't meet those, the staff the nurse that was primarily taking care of the patient would complete a chart review audit on this patient, and that helped so that they understood when they didn't meet it, that they were to have to do a chart review, and that chart review helped reinforce the time metrics and what the importance is. So it was kind of our opportunity for improvement method to allow them to really understand the process. Next slide. And then our last cycle, which was January through April, is where we continued to educate our providers about the positive feedbacks and about the activation time. And what really changed our process, and what really is, because I helped facilitate this, but the ED providers and the nurses, they own this process. This is theirs. They have done all of this work. And I will say now, at the end of April, our overall mean was 28 minutes, and we were 100% compliant for all less than 60, 45, and 30. And it's just changing their mindset and getting them involved and them owning this. And before I can even review a code stroke process, they've already reviewed it. The staff have already reviewed it that were involved in it, and then the ED manager reviewed it. And so by the time I get to it, it's already a third check. I don't get notified when they have a code stroke, so I'm not down there in their process watching them and probing them, to do it. So this is all them, and giving them ownership of that, and letting them know the times when they've done well, letting them know great outcomes. They have really become what we call the stroke fever. They got the stroke fever, and it really has significantly changed our numbers. Next slide. So overall, you can see our door-to-needle times. This is the door-to-needle time for 60 and 45 is the same yellow color. So as you can see, we did well with that. Our door-to-needle time less than 30 since December. We've now maintained 100%. I will say since April, even through our COVID, we have continued to maintain 100% compliance. So very proud of our team for that. Next slide. So magnitude of our results. So overall, since we began our process in June of 2018 until now, we've increased our compliance rate for getting our turnaround times for our imaging. We've increased went from 0% compliant to 100% compliant for all of our door-to-needle times, and then overall 51-minute decrease in door-to-needle times. And the only way you're able to do that is just to have them own the process and really understand the reasons why we do it. It's not about just hitting a number. It's about every single minute, every 3 minutes that we increase the time. If we're saving brain cells and improving patients' outcomes, and letting them know that and giving them reasons and to treat versus finding reasons not to treat has really helped our program as well. Next slide. I think that's about it. Next slide. Next slide. And yeah, just how we're going to sustain that is to continue to provide education about our turnaround times. We maintain our stroke, audit our stroke logs monthly, and I do give them weekly feedback on the code strokes and let them know how well we're meeting all of our metrics, and then continuing to share that with our group for process improvement. So that is all. Like I said, this is the beginning of that. I help to guide them through this, but our ED staff get all the credit for this. So I see we have multiple questions, so I can't see them all, but if y'all can let me know what the questions are, I'd be happy to answer.
Yeah, so it's Deanna. So then the first question is your presentation part of the presentation that we will be sending out to the group within 1 or 2 weeks? Okay, so yes, to the question, it will be a part of the presentation. And we will send you a copy of this presentation within 1 or 2 weeks after this call. Okay. The other question is, can you share what the stroke champions wear on their badges again?
So the stroke champions it's I found it at the stroke conference. It's a little it's a badge holder, and it's a kind of a velvet or kind of some kind of fabric little brain that's on there, and that's attached to their name badge. I got them at the stroke conference.
Perfect. And can you share the checklist with us? Absolutely.
And if anybody wants to email me, I will be happy to share anything that I have, because we are all in this together, and if anything that I have I can help someone else, absolutely. So just email me and I can share anything with you.
How big is your hospital?
We are I will say we are probably one of the smallest comprehensive centers. So we are very small. We only have a 161 bed hospital. So yeah, we are very small, but most people would label us as a high risk, low volume facility, but we really aren't. We are doing great, no matter what size you are. You can do great things no matter what size of hospital you are. A lot of the comprehensive stroke centers are the big university hospitals and the larger ones, but we're here and we're very proud, and we've worked very hard to get where we're at.
Do you use neuro-telemedicine?
We have our own neuro hospitalists that take calls, so we don't use any telemedicine or telestroke process. They're in-house and available. There's a group of 4 of them. We call them our neuro hospitalists, and so they take all of our call in our ED.
How did your radiologists on board to call the ER physicians get on board to call the ER?
It was a real simple process. As soon as they get the result, they read it, they instantly call. So the call time is what we use for our turnaround times and not the dictated time. We invited them and we included them in our code stroke process, and they were the chief radiologist that's here. He was in every single one of our code stroke meetings, and so he was there at the beginning of the process, and so he helped to kind of make decisions. So involving them lets them feel a part of the team, and it was no problem.
Okay. What is your average monthly number of points who receive, and I may say this wrong, Alteplase? Alteplase. Thank you. It's like, sorry, not a stroke person.
So our average monthly, we can have anywhere from 2 to 3 a month, and then during COVID, we could have 1 a month. But I would say on average 2 to 3 a month. So we don't do a lot.
Okay. And can you provide your email so that they can email you? On the chat box would be great.
Yes, I can. I will send it to everybody on the chat box.
And then the other question is, did you use a specific method for getting your physicians on board to make the decisions quickly? specific research articles, publications, findings of such as?
So they actually, a lot of them participated in the Genentech put out this disability. They had this little speech they used to give about looking at patients' disability versus looking at the NIH score. And it was one of their disability slide decks that I had invited all of my ED providers to attend, and they did a dinner presentation on it. And so a lot of them attended that. And then a couple of months later, they sent it out as a webinar. And that presentation was such a huge eye-opening experience for my ED providers. They really, really got more comfortable with Alteplase. And that helped a lot, just giving them the data and the information, because naturally they're so scared of Alteplase. They don't want to give it. They're afraid to give it. And so the more comfortable you can get them and show the positive outcomes, and just showing your own data helps a lot.
That's all the questions I had on the chat. If anyone wants to come off mute, if you're on your phone, you can star 6 and you can ask questions to do that.
I think we're going to go ahead and move on, just because we have so much to cover. But thank you so much, Shantah. A big shout out to Baylor Scott and White Plano. This is a great accomplishment. And thank you for sharing the information. Okay, so next is we're going to talk about the COVID-19 cases. So Allison is going to be taking over. Allison Capetillo, who is a director for our Southwest affiliate with an expertise in stroke. So Allison.
Hi, can y'all hear me okay?
Yep.
Oh, perfect. Okay. So I'm just going to quickly go through some of the preliminary data that we've pulled out of Get With The Guidelines. A lot of this information you'll be able to, you're welcome to go back and run yourself if you run with the benchmark group Southwest region, or you're welcome to look at it by state or for the whole country. So I didn't really pull anything that y'all can't get yourselves, but please bear in mind that this is very preliminary. We're still kind of getting hospitals submitting their data, especially for the last month or two, and that these numbers probably will change in the next several weeks. So what you're looking at right here is just a map of the country. This has been updated on the 6th, so just yesterday, using the New York Times interactive COVID cases map, or I guess search tool. And you can see we've highlighted it by region. These are the AHA regions, I apologize. And so the red one is obviously our Southwest region. And so we're looking at just a little under 290,000 cases for the entire region right now. Next slide. Deanna, oh, sorry. Okay, you can go ahead and go to the next slide. Okay, so first thing, top of mind, I think everyone's just kind of got it on their minds of, what have our volumes looked like for the last several months as it relates to COVID. And I kind of did like a comparison of Southwest versus the nation to see if there was any, big discrepancies or anything like that. And I also did a comparison against the same time last year so that you can view where we were at this point last year. And I think you can really see a marked difference in the comparison of the the 2019 versus the 2020 numbers. You can start to see, especially April and May, there was a pretty drastic decrease in the number of ischemic strokes coming in for those 2 months. So it really started to taking effect, I think, later in the spring. And I know that we've all been hearing that these, volumes are decreasing, but I wanted to show you in a graphical format that how that's the case. And if you look at especially May, you can kind of start to see there's almost like a 50%, close to about 50% decrease in the number of cases coming in. Next slide. The next view I'm showing you, this is ischemic stroke volumes by state. So I went and pulled them by state. This one would be a little tricky for you guys to pull out because I don't think you'll have access to all the other states. However, I did this in a way, it's a little confusing, but on the left-hand side, you're looking at the total stroke volumes for each state as reported February through May for 2020. And then on the right side in red, you're looking at the percentage of those cases that are reported as COVID positive as a part of that total for your ischemic stroke volume. I will, however, put a caveat on this slide. There are not a lot of people at this point that are utilizing the COVID information. I think because it's just not a required element. It doesn't seem like there's a lot of hospitals putting that in at this point. So I think as we get people more comfortable with adding, whether or not a case was COVID positive, then we will start to see a little bit better reporting of the numbers. But I do want to also point out that if we're talking about overall percentages, most states are reporting that a population impact of about 1% is when we start to realize that there's a problem in that state. And anything higher than 1% obviously is a big problem. I think Texas is like 2.8% right now, and maybe Florida. And there's some other states that are being heavily impacted right now that are at higher than 1%. So this actually is not all that surprising when we start to think about how it impacts the stroke volume or the stroke population, that we're seeing numbers that are just, under 1%. I think Colorado's got a little bit more significant number, right at 0.53% of their strokes hitting as COVID positive. So I guess next slide. This is just looking at how was Alteplase administration hit during the COVID months. So again, February through May. Honestly, I'm not seeing a huge issue here. I don't really see, this is the timed IV thrombolytic percentage compliance within 60 minutes. So if you look at even, in the heavier hit months, April and May, folks are still hitting greater than 80% of the time, hitting the 60-minute mark. So that's good news. I'm glad to see that because we had a lot of worries in the beginning of, is it going to cause delays because of donning of PPE or testing or any other, issues that might come up in the ED. So this is actually really positive that we're not seeing a big decline in the number of people hitting the 60-minute mark. Next slide, please. I also wanted to pull out what the numbers are, the average time to IV Alteplase for each of those 4 months as well, February through May. And so you can kind of see we were on trend, doing pretty good, February, March, April, right around the 47, 48-minute mark. A couple of outliers, maybe up around 60 minutes. And then we did have some odd, discrepancy in the month of May in the Southwest region. The average time ticked up to 94 minutes. I don't know if that's because we have some outliers in the data that possibly have very extreme times that are still being included and maybe need to be excluded at some point. This will all just depend on how many hospitals go back and really take a look at these times and see if the data is accurate. Next slide, please. I also wanted to present it as the median time, last known well to arrival. The last known well to arrival, I think I wanted to check because we, worry that people, weren't either calling 911 or calling EMS to even go to the hospital at all when COVID started. So I wanted to know if that had been really heavily impacted. It looks not terrible. I think in April we saw a little bit of an upward trend around 290 minutes after last known well. But by and large, I think it's stayed about the same as it was last year. So it doesn't look like people are waiting too much longer to go to the hospital, but I think we'll keep an eye on these numbers just to see if trends will change as the pandemic goes on. Next slide, please. The other thing we wanted to take a look at is arrival mode. Looking at if there were changes in the number of people arriving via EMS versus the number of people arriving as a walk-in patient. I think primarily what this shows is, again, you're seeing that marked decrease in volume for 2020 versus 2019. You're not really seeing, I don't think if you're looking at percentages of, patients arriving via EMS versus walk-in, I don't know that you're seeing all that big of a difference. Maybe a slight increase looking at May and April, a higher percentage of cases were coming in via EMS. So So that is encouraging, but again, something I would say we probably want to keep our eye on as time goes on to see how many people are coming, personal vehicle versus EMS. All right, next slide, please. Okay, so that's all I have on the data. I do see a comment. We saw much more change in stroke alerts. Mimics and TIA volumes dropped off. Yeah, I think that'll be an interesting thing to look at as well. I may have to pull some data on that, Danielle, and look at the TIA volumes too. So just looking at some educational opportunities that are available currently. There are lots of webinars that have been coming out lately, and if you didn't get a chance to catch them on the live, webcast, there are links to the recordings that are going to be found within the slide deck. So when you guys get it, you're welcome to check those out. There was one called Stroke and COVID-19 Cases from the Front Lines. That was a really great discussion. The panelists on that, I believe, were up in the New York Northeast part of the country, so they were really hit hard early on, and they had some good information to share of things that they were seeing early in the pandemic that kind of, I think, led us all to start looking a little bit harder at how COVID was affecting stroke. The next one was the Stroke and COVID-19 Special Considerations webinar recording. There was a Get With the Guidelines update webinar that was on the new guidelines. If you didn't get a chance to catch that and you want to just get some information on the new guidelines that came out in 2019, you're welcome to check that out. There's a Mission Lifeline Stroke webinar that looked at data collection and best practices for partnerships with EMS. And there's always a lot of good stuff on the Professional Education Center. The links to the Professional Ed Center are here at the bottom of this slide. And if you're having any difficulty logging in, the customer service number is there at the bottom as well. Next slide, please. This is the link to the temporary emergency guidelines that were released during COVID. This is just a little 3-page document, really just giving some ideas of things to look out for and maybe some practices to incorporate during COVID that might affect your ED processes. Next slide, please. There's a webinar that was on April the 8th that was one of our Southwest region webinars. And this was another panel discussion. A few of our physicians hopped onto that and were kind of just giving their experiences and their guidance on what they'd seen in their hospitals as well. It's the Southwest region discussion. This was presented early on in the COVID pandemic. And the June 30th recording is all about the updates to the PMT that came out on the 27th of June, and lots of new guideline incorporations in that webinar. Go ahead, next slide. If you didn't get a chance to catch the mild and rapidly improving presentation that was presented by Dr. Cheryl Martin-Shield, she did a wonderful presentation back on June the 22nd and gave a lot of information. This might go in line with Shantah's presentation, when to treat or not to treat for mild stroke symptoms. Really, really great presentation. So the webinar for that is down at the bottom. Next slide. If you are a new coordinator or a more seasoned coordinator and you are looking for some CEs or you just want to get a little refresher on some stuff, there's a virtual stroke coordinator bootcamp that was put out by our friends in the Midwest affiliate, and it is available on the professional education site. This one is a low cost of $50 for the whole bootcamp, and it will provide you with 7.75 CEs. You can listen to these at your own pace. I think they're just like 1 hour little webinars that you can kind of listen to when you're ready. And you don't have to listen to all of them. You can do partial or whatever looks interesting to you. Next slide. And of course, we still have the Enduring Bootcamp that was put on a couple of years ago by the Southwest region that was all recorded. All of the recordings are still on the professional education website. that is a total of 15 hours. So if you're looking for some, you don't have to listen to all of it. Again, you can pick and choose what looks interesting to you. I think, 1 hour gets you 1 CE, obviously. So if you want to listen to 5 or 6 of them and get yourself some hours, that's a good way to do it. And this one is free of charge. Next slide. I think, Deb, are you taking this part back over?
Yep, I can take it back over. Thanks, Allison.
All right, thanks, everyone.
So I just wanted to kind of share some information about how you can promote your stroke awards that you should be receiving. Again, hopefully the end of the week, you'll start receiving them, or next week. But, your success is definitely worth sharing, and then promoting your Get With the Guidelines Award, winning hospitals, EMS agencies, and Mission Lifeline. So one thing you can do is internal communication. I'm going to go over these really fast because you're going to have this information. But you could do table tent ads on services in your patient waiting areas, your cafeterias, with your icon. You can mount signage in the restroom walls that are framed. You can hang banners on your main entrance. I've seen like huge banners from the top of the hospital all the way to the bottom. You can place a small ad or sticker on a daily patient menu. Use your slide to announce your award on internal closed circuit TV, place an article in your hospital newsletter, and then also send memos to your hospital board of directors, CEO, and other hospital stakeholders, letting them know how wonderful you're doing, how great you are, and how you're doing best practice care. You can also add the icon to your signature line so that when you send your emails, that will be there. Ideas for virtual recognition. You can schedule a ceremony at your hospital or agency and inviting key members, local dignitaries, broad members, and the media. So you can do that virtually. Hospitals can invite their EMS to your celebration. The EMS agencies can invite hospitals to their celebration. You can ask your Get With the Guidelines champion to provide a recap of the program. You can have photographer documentate the certificate or award presentation. So there's just a number of different ideas again here. Have your award presented at a community event such as the gala, or even better, a survivor event. You can promote your award in the community if the hospital and EMS are both recognized, come together and promote your award as a system of care. Place an ad or a banner on the homepage of your website, use a billboard, local newspaper ads. You can announce the award on your on-hold message recordings. And if you have a hospital pharmacy, announce your award on the pharmacy bag or with a flyer in the bag during key months. I even saw somebody put one on like a grocery sack. They partnered with a grocery store and had their logo and their award on the grocery sack, which is kind of cool. LinkedIn is another way. You can share your awards on LinkedIn. Other social media, you can share it on Twitter, on Facebook. Your Get With the Guidelines Achievement Awards. Just sharing them. So those are just some quick, easy ways. And it looks like we have 2 minutes for questions. So I know we went through this very fast, but there's a lot of information. And again, you will be receiving this information. So are there any questions for these last couple minutes?
Again, you can go ahead and type it into the chat box or come off mute by pressing *6 if you're on the phone.
No? Okay, and with that, then we'll say good afternoon to you. Have a great day, and thank you for joining us today. We really appreciate it. Have a good one.
And Deb, just to let everyone know, these slides will be sent out to you all within 1 to 2 weeks of this presentation. And again, if you have any questions, feel free to reach out to Deb or Allison. Have a wonderful day.